Okay, let's talk about public health surveillance. So this is basically conducting surveys, or if you want to be more specific, it's the systematic collection, analysis, and interpretation, and the dissemination of public health data. This is obviously critical in that it helps us generate hypotheses, test hypotheses, conduct studies, but it all starts with surveillance. So let's think about what it is like to conduct a survey. We survey for a variety of diseases, and hopefully, well, in public health sense, it is always conducted by competent epidemiologists. I was going to say, hopefully it is conducted because people conduct surveys all the time. It doesn't have to be necessarily a professional who works for the CDC, but data are being collected constantly about different diseases, either by the CDC or by researchers. There's two broad categories of surveillance. One is passive surveillance and the other is active surveillance. In passive surveillance, we depend on reporting by people in the field, right? So for instance, with a disease that's what's called a notifiable disease, these are more severe diseases that we really need to have information on. We rely on healthcare providers to provide us with numbers. That's all good in theory, but sometimes people are very busy and they forget. So while those data are really reliable to a great extent, or the source is reliable, sometimes just people, because of people being busy in the field, we're not always going to get the most accurate results. But anyway, there are certain diseases that are considered notifiable and you have to report them. So according to the CDC, a notifiable disease is one for which regular, frequent, and timely information regarding individual cases is considered necessary for the prevention and the control of the disease. Obviously, with SARS coronavirus 2, that is a notifiable disease, as is Ebola, as are a lot of rabies. There are a lot of different ones. You can actually click the link here to go to the CDC site to find out what the notifiable diseases are and how many cases there are per year. Active surveillance is when somebody goes out and actually surveys. So that would be something like what John Snow did when he did his shoe leather epidemiology, walking through Soho to find people who had lost family members to cholera. It's similar to the kind of research my colleagues and I do when we look at smoking. We actually go out into the field and collect data actively, having people fill out surveys. These are more accurate because we have more control over them, right? In a sense, we're going out and doing it. We're not relying on other people who are otherwise busy to give us the data. Let's talk a little bit about descriptive epidemiology. So this is basically providing information about a disease, or doesn't have to be a disease, about a condition that could lead to a disease. So for instance, obesity or being overweight isn't technically, I wouldn't consider it a disease. However, it is something that can lead to a variety of diseases down the line, like type 2 diabetes and heart disease. The same with smoking. One would say, okay, cigarette smoking is not a disease. Nicotine dependence is, but people are more concerned generally about lung cancer, emphysema, and other chronic obstructive pulmonary diseases. So, but these processes, because they're linked to a disease down the line, I would also consider them as diseases. So when we provide descriptive epidemiology, we provide numbers, right, like proportions, or the number of individuals, and it's based on person, place, or time. Person being number of individuals, location, and time, for instance, by year. These data are really important because, and this is what we're going to be doing some of this today, but data like these provide us with the ability to generate hypotheses. We look for anomalies, just like I mentioned before earlier in the semester, how observation is key to being able to generate hypotheses. So we're making these observations so we can generate these hypotheses and hopefully lead to change. We want behavioral change, but we can't start until we have a better understanding of what's going on. When we talk about person characteristics, we talk about age, sex, race, ethnicity, marital and family status, occupation, education, travel habits. So if you probably, as you probably are aware, anytime you go to a healthcare provider, generally you're asked if you've traveled out of the country. That actually started because of Ebola, right? Because Ebola was so scary. I don't know if it was maybe somewhere 2014, 2015. That was a very scary situation. So people were immediately asked, did you travel abroad? Because we didn't want people bringing Ebola into the US. But now also with coronavirus, it was similar, especially in the beginning of the pandemic. Place is location. Sometimes location can impact a condition. There's this tendency now to do mapping. So we like to map locations because sometimes pictures can present greater information or have a greater impact than numbers. As I noted earlier, when we looked at John Snow, and he made those maps of Soho to show you where the deaths were, so that just the impact of those pictures was great. Here's an example from something that I've done. Let me see if I can get this to work. Okay. Maybe. There it is. Let's see. It's going to work. Here it is. Okay. So takes a second here. So this is one of the papers that I published that shows a mapping of Philadelphia and Trenton. And I may have already shown this to you, but again, so this is an example of the impact of mapping, right? So you can see that wherever there was a greater density of people and a greater density of African Americans, Hispanics, people living in poverty, there was a greater density of tobacco outlets. So those outlets seem to mirror some of these populations, particularly here, and here where the proportion of black people live. So this was interesting kind of use of mapping. But again, this is descriptive epidemiology in that it provides us information that we need in order to generate hypotheses. And then time, we just look at what happens over time. So we talked about trends already, right? So we look at issues. Like I know that when I go to one of the websites, the Washington Post, and I look at what's going on with, let me actually maybe I'll go to a different website. Let's see. Johns Hopkins coronavirus map. When I go here, you can see, let's see if they have one of these. Looking at trends, it may or may not. Actually, Pennsylvania might have a better one. Let's see, Pennsylvania, blah, blah, blah. So, yeah, here you can see, this is what I'm looking at. So you can see how the weekly cases were going up, and then now they're really, really down, going down, down, down. This is globally rather than in the U.S., right? So especially in the U.S., when we look at what's going on in the United States, we see the data change greatly. Yeah, so I believe this is globally. So, but you can see that there are trends occurring. In particular, in the U.S., we have like a great decrease. Let's see if we can find a U.S. one. I don't know if they would show this. Let's see. Let's see, United States. Let's see if we can find this. It's Los Angeles. Let's see, U.S. map. Not everything's always that easy to find. You got to look for it. That's why we call it research, right? Try Pennsylvania. Here, this is what I wanted to find. Yeah. So if you look at what's happening here, we can see time. There was this massive increase, and we were all scared and think we were doomed again because of Omicron, but then we get to where we are now, we're down to a really, really low level. So our incidence is 940. I don't know if this is reported per, or is this just plain new cases? 7-day average is 1046 per day, right? So I guess it's just the number of new cases. So this would be great if this is just 940 new cases. So, but anyway, you can see that things are thankfully slowing down a bit, and that's why we have these changes in masking, and hopefully this will be able to stay. Although, as you may know, in my courses, we're still wearing masks. The public health department wants us to continue wearing masks. I like to see, a 3-month change. That's my goal. Then, I'll be happy. Let's talk a little bit about unexpected. So when we report data, sometimes you see these massive shifts in incidence and prevalence, and that could occur because of a variety of issues. And one of them that's actually, to me, is most important is a change in case definition, or even inconsistent interpretation and application of case definition. So who is a case exactly? How do we know that somebody is ill? And that's something that's, to me, it's extremely important. Like when we're talking about a disease like coronavirus, how do you know that somebody has, what this differentiates somebody having the flu versus COVID-19? So the case definition is extremely important, and the application of the definition is extremely important. Surveillance is important too, people reporting, right? So if more people start reporting that they're ill, like say if we change the case definition and excluded fever, more people would have reported ill, and maybe we would have had more people test and had greater level of infections over time. But another issue that we'll talk about much later is the efficacy of diagnostic tools. So not all of them are equal. So even though when somebody reports that they tested positive, we just assume that they're positive, but that's actually not the case. We'll actually talk about that later when we discuss sensitivity, specificity, and positive predictive value. All right, let's look at some interesting statistics. And so these were discussed in your textbooks. I want to cover them here. One of them is the dependency ratio. And I'll show you an application that I did of this myself early in the pandemic. So what is the dependency ratio? Well, it's the ratio of people lower than 15 years of age or 65 and above to those who are between 15 and 64, right? So what we want to know is, so these individuals who are below 15 and greater than 65 are generally being taken care of by individuals who are between 15 and 64. I got a few more years left where I can take care of people, but soon enough you'll be taking care of me, right? So the dependency ratio in the US was 51%, right? So it's percentage, so it's per 100 people, right? 51%. So there were 51 dependent on every 100 people of working age in 2000. And you notice that by 2025, it's expected to be 61. Although this is interesting, it might change now. These were earlier projections. It could change because of the massive number of deaths among older individuals due to COVID. So this could change, right? I mean, it's sad. We've had I don't think we've reached 1 million yet, but we're around 1 million deaths that are attributable to COVID-19. So that might actually have some impact, although, we have 330 something million people, so it's going to have a small, but it could have some impact on these dependency ratio projections. So what we need to do is, basically this is saying, like for instance, by 2050, the estimate is there'll be 67 dependent people for every 100 people of working age. That's a lot. So that means there'll be a lot of people to take care of. So this is something that I did. So this was something that I just came up on my own because I was, obviously, like all of us, we were sitting at home, and they say the devil finds things for idle hands to do. So my expression is the devil finds things for idle minds to do. And I was sitting around and trying to figure out what's going on, as all of us were. So I started looking at the data every day, and one of the things I thought about in relation to dependency ratio was do countries that tend to take care of their senior citizens have lower case fatalities? than countries that don't. So case fatality is the probability of dying if one is infected. So I came up with this number. So that it's hospital beds per 1,000 population. So these data were available, I think I've got them from the World Bank website. And I also got the proportion of population greater than or equal to 65. So I call this the HB65. So see this, so this is a ratio, right? Hospital beds per 1,000 to percent of population above 65. So that's something that I created. And then I also looked at case fatality. So this was back in, this was some point last year. I can't remember the exact date, but I looked at these data, and here you'll notice these are the hospital beds per 1,000 per 65, or the HB65 index. So some countries like the United Arab Emirates, where it's quite a wealthy country, have a lot of hospital beds per 1,000 for individuals that age. Singapore is another country that's like that. The U.S. was down here. Now, I'll make this point that the data were difficult to attain because not every country reports, and some of the data were older than others. So these are only estimates, right? Here you have case fatality. So you'll notice how there's this inverse relation. So this line is like the best fitting line, this dotted line, for the data, and you'll notice that it's sloping upwards, whereas the case fatality is essentially sloping downwards. There's like an inverse relation there. That's pretty amazing. So that's an example of where if you take care of your elderly, and again, I'm not looking at those below 15 in this case. I was only looking at the HB65, people 65 and above, because of COVID-19 having a massive effect on the older individuals. Pretty cool stuff, huh? All right, so let's conduct some surveillance. So this is actually an assignment. I'm going to post it for the end of the week before spring break. It shouldn't take you that long to do, so don't say, oh man, this is like the week, this is pre-spring break week. But this is actually going to be fun to do. So first thing we're going to do, I'm going to have you do is go to this data set, Youth Online Data Analysis Tool. So click here, and it'll take you to this website. And you'll want to go down to this area right here, right? And click, let's whatever you want to use. So I'm going to use the example of obesity and overweight. So I click that, and I have this page come up here, okay? Okay, so this is, you can choose any year you want. I chose 2019 because that's the most recent data set available. So we'll give you your assignment. Well, actually, I want you to work by yourself, working alone. You're to compare youth in 2 states of your group, of your choice. Okay, no group, I'm going to do this alone. Your choice on some public health issue. Make sure to select your states, condition, population, and grade. Or you can do all grades if you want. So here's an example. Do Hispanic high school students differ in obesity when comparing California and Florida? Also, do males and females differ in obesity when comparing males in the 2 states and females in the 2 states? So compare males versus females in both states, California versus Florida. Comparing males to males in California versus Florida, and females to females in California versus Florida, as well as just total males and females in both states. So here's my hypotheses. The proportion, hypothesis 1, the proportion of obese Hispanic high school students in California will differ from the proportion of obese high school students in Florida. Okay. Hypothesis 2, the proportion of obese high school males in California will differ from the proportion of obese high school males in Florida. The third one is the proportion of high school females in California will differ from the proportion of high school females in Florida. So provide results. So you have to make sure you're I'm going to say write write out your hypotheses. I'm going to add that here. Write out your hypotheses, like this example. Now remember, you can pick whatever you want. It doesn't have to be Hispanic, it doesn't have to be males. It could be any race, ethnic group. You could do whatever you want, make any type of comparison you want. All right? And we're going to provide results in terms of proportions and confidence intervals. Test the difference for statistical significance. I'll show you how to do all this. This is actually really easy using this tool. So this is an example of the results, and I'll show you how I derived them in a second. Like I wrote Hispanic high school students did not differ significantly on percent obesity from when comparing California, and I put the percentage here and the confidence interval. All this is available to Florida. Actually, I should do this here to Florida. I forgot. I'm glad we're doing this together, so you can see what I'm doing. Although the difference approached statistical significance, and I provided the p-value. So when I say approached, was generally people like to use alpha of you took stats, so people like to use alpha of 0.05 to indicate statistical significance. For something to be statistically significant at alpha of 0.05, it would have to be lower, and 0.08 is greater than 0.05. So this is not considered significant, but it's very close. That's why I say approach. Only Hispanic males approach significance when comparing the two states, so females did not, with a percentage higher in California, right? Oh, I did this again here. Okay, good. Let's see. So this is the proportion, right? And then this other number is the 95% confidence interval. Now the reason I made these errors is because you'll see that I just copied and pasted the material, but then I had to make the change so it would read better. So this is approaching significance too. It's 0.07. So that's how I want you to report it, but you're going to obviously write up what you wanted. But you're going to write your hypotheses first, like I did, and then the results. So let's take a look at how I derived this stuff. So I went here. Okay, so what I wanted to do is you can choose whatever you want, right? Sexual behaviors, dietary, I chose obesity. I wanted to view two locations. Okay, location one, I said it's a state, so I go to states, and I hit California. And then the second state I chose was, I think it was New York, right? Or Florida, states, Florida. Both of these states have a lot of Hispanic individuals. So now it's going to compare those two states. So it says view data by subgroup will be sex. You can change a subgroup if you want to be anything. I just chose sex. Greater risk, okay. 95% confidence interval. This is all set up, so you don't have to really have to do this. Display cell size. You don't have to display cell size. Like here, you'll have cell sizes 12,140. I could suppress that if I want. So doesn't seem to be that important. So we're comparing those two states, and in terms of race and ethnicity, let's see, location. I think we're just okay. So we have to set this. Oh, here I'm going to say I want to reduce it to Hispanic or Latino. So this reduces to Hispanic and Latino. So it takes a second there. Okay, so now we're comparing Hispanics. So there you go, it did it. Hispanic and Latino. So I have, check this out, I have California, I have Florida, right? And I have the percentages. So these are the percentages with it. So you see when I just copied this right here, that's why I had to rewrite that. But this is the percentage total of individuals who are obese, and their obesity is defined as students who were greater than equal to 95th percentile on body mass index. I mean, they weigh more than 90, they weigh equal to or more than 95% of all individuals in the population. Okay, so that's that. Now, if I want to compare them, compare the two, you click them. So, although I don't know if you need to really click those two because it's a compare to. So this will get us the results that we want, and it may take a second here. So we can get the p-values. But at any rate, so this is, I want you to choose whatever you want to do whatever you want. So this is just an idea to get data so that you can generate hypotheses for whatever, I don't know, whatever hypotheses you want to do. So this could take a little time. So again, so that's how I ended up arriving at what I want to do. When this comes in, you'll get the p-value, although for some reason it's very slow right now. But it'll show you the p-value and tell you whether, so you can make a determination whether something is significant or not significant. All right, oh, here it is, okay. So here's the comparison total, right? P-value. This one, so again, p to be considered statistically significant has to be lower than, honestly, it doesn't matter what that alpha is. Alpha is the probability of a false positive result, basically. A lot of people choose 0.05, could be 0.01, could be 0.10. With this sample size here, I'd say this is 0.05 is fine. You can go even 0.01, but this one and this one are closer. This one is 0.85. This is saying that the probability of this observed difference, if the null hypothesis is true, null hypothesis is that there's no difference between the two, statistical language, is really, really high. So this is definitely not significant, but these other two are close, right? So here I think that they would tell you if there was a difference, because people don't really generally know, but just you should be able to read this and write it up. Okay, so that's your little assignment, and I'll post it. Thank you very much. This was fun. Have a good weekend, rest of the weekend.